welcome to the MedEClasses PG lecture series in which we will be talking about a very important and interesting topic of DSD. And this is something which is extremely common, extremely important, and has got huge implications in terms of evaluation and management. So, Dr. Vibha, why do you think DSD is one of the most enigmatic part that we deal in pediatric endocrinology? What are the challenges that are there in terms of evaluation?
So first of all, the identification whether there is a DSD or not, because some of the DSD mimics may cause confusion, and one of the most important consideration is the excess DSD, which is 21 hydroxyl and which is a life-threatening condition. So identification of excess DSD in an early stage is very important to prevent the grave consequences. So in these scenarios, this is important to identify the DSD at the right time.
And what are the common forms of DSD that you encounter in our clinical practice?
The most common that we encountered in OPD is 21 hydroxylase, and the in pubertal age group aromatase deficiency, and rare form of 11 hydroxylase, rarely we do get.
And of course, XYDSD is one of the ones which are
XYDSD, yes,
very
sir, definitely
challenging.
in the boys, XYDSD, 17 beta HSD, and 5 alpha reductase we do
So
have.
XY is something which is often very challenging to diagnose and much more difficult. XS seems to be important because of clinical relevance. So both spectrum becomes important. So what we'll do is that over the next hour or so, we're going to discuss about the pathophysiology, the etiology, evaluation and management of DSD. And at the end, we will have objective structured questions which will be done by Dr. Nimisha. So we'll start off about DSD. And DSD is something which is extremely important to identify, as discussed by Dr. Vibha, because there are lots of implications. So we'll talk about two cases where the diagnosis made a big difference. So we had a 1-month-old boy, child with DSD, who was referred to us with Prader stage 4. And what really happened was there were classical features of XY-DSD. Now, this individual had been given testosterone, 3 doses, and people thought that this is XYDSD. We have done our picture and then we'll go for surgery. But unfortunately, despite the various increase and everything happened, 5 years later developed renal failure. So what's very important to understand is that our job is not just done by identifying a DSD or giving some cosmetic measure. We also have to think of a serious underlying disorder, which could be something like a WT1 defect, which can result in renal failure. So a comprehensive evaluation of DSD therefore is extremely important. The second scenario was more of a diagnostic challenge, a day 3 child with DSD who again presented with Prader 4 with no gonad. So this looks like XX DSD, and on further evaluation was found to have the Mullerian structures, and the karyotype was 46XX, again confirming. At that point of time, a borderline 17 OHP was identified, and based on that, a diagnosis of 21 hydroxylase deficiency was made, and the child was labeled for life in terms of treatment. Now, what happened by the treating physician was that they found that they could actually cut down on the dose of hydrocortisone, and the 17 OHP remained normal, which really excluded CAH as a possibility. If you look in retrospect, the amount of 17 OHP elevation was not remarkable, and this brought us to some alternate diagnosis. And when we evaluated, we found that there was delayed puberty. Now the child presented around 14 years of age with delayed puberty. On retrospect, there was a history of maternal virilization, giving a clue to aromatase deficiency. The key message is that if you identify XYDSD, don't just get satisfied with the diagnosis and treatment, think of an underlying cause. And not all XXDSDs are CAH. This is something which is extremely important to understand from that regards. All of you can go and have a look at our website learning.society.in, which has got multiple source courses and resources, including fellowship in pediatric endocrinology, our e-learning platform, the YouTube channel, which has got large number of information available. We have got courses which are available, and including fellowship and postgraduate programs which are there, which can be accessed online as well as on a hybrid mode. We run regular programs in the form of grand rounds, journal clubs, and PG lecture series. This lecture series is part of a 36 lecture series which aims to cover the entirety of pediatric endocrinology over a 3-year period. We have already conducted around 15 such lectures. They are all available on YouTube. You can go and have a look at that in detail in terms of that. There are multiple publications which provide coverage in terms of pediatric endocrinology, right from protocols to basic and to advanced pediatric endocrinology. Our latest application is now available on both Android and iOS store. It looks into entirety of pediatric endocrinology. So we'll talk about PG lecture series. I'll be joined by our consultant in pediatric endocrinology at Regency TDR, Dr. Vibha, who will be talking about etiology, and Dr. Nimisha, our fellow, will be talking about some very interesting cases.
This 7-year-old boy who presented with ambiguous genitalia and examination, there was normal growth and blood pressure was within normal limit. And on the genitalia examination, the labia appeared bifid. There were 2 separate perineal openings and the phallic length was 2.5 centimeter. There was no palpable gonads, and on the USG we find that the Mullerian structures were present.
What will be the likely diagnosis here? People can put it up on the Q&A section. So we have a 7-year-old child who comes to us with basically gonads absent and Mullerian structure present. So this is clearly a case of, I think we have people are answering the question. So we'll see if there are any answers there. So this is looking like CAH. Do you agree, Vibha, with that diagnosis?
Sir, definitely this is CH, but as on the examination, there is a no growth failure, and so it's more likely not to be a classical CH. It can be a form of simple viralizing CH.
So this is definitely, we can say this is a CAH. The important thing which is missing, so which physical examination, BP we already mentioned. So BP is normal, which goes more in favor of a simple
Pigmentation, they have none.
CH, and pigmentation, I think, is something which will be a clue. So Dr. Irshad Mondal and Dr. Priska has given the right answer of XX, DSD and CH. So we'll go on to the next case. We have a 3-month-old child, male child. You carry on.
So it's not coming to the screen.
It's there?
No, sir.
No, you can't see it.
No, sir.
It's been shared.
It's not visible, sir.
So you stop sharing, I think.
Nimisha, you stop sharing.
Now you can see?
Now I can see.
Okay.
So there is a 3-month-old male child who presented with normal genitalia, and he also presented with severe dehydration. There was on electrolytes we found that he has a hyponatremia along with hyperkalemia, and see what is the most probable diagnosis in this case.
So we have a
everybody
3-year-old male child with normal genitalia with severe dehydration, hyperkalemia and hyponatremia. So Dr. Aisha has mentioned CAH. Any other diagnosis? Dr. Medha has also mentioned CAH. Salt wasting CAH, Dr. Irshad. What do you think, Dr. Vibha?
So, in this case, CH could be one possibility, but we can also think of this pseudo hypoaldosteronism because it's a male child and with the normal genitalia and with this presentation. So, it could also be a
So we have to think of other possibilities. As you said, adenohypoplasia congenita can also be an important thing, which can be the DAX1 defect. There could be PHA. So which test will give us a diagnosis? Anybody from the audience? So I think the first test which everybody will do in this case will be
17 OHP.
a 17 OHP, which will give us a clue from that. Regards. Next case.
So we have this 1-month-old newborn, 1-month-old born who was born to the 3rd degree consanguineous marriage. And on examination, the gonads were palpable and the phallic side was only 0.5 centimeter and there was labioscrotal fusion. And on the USG, there were no Mullerian structures.
So we have a child who has got palpable gonad, no Mullerian.
But no Mullerian structures.
So what is the type classification from the audience? Which form of DSD are we looking at here? Gonads present and Mullerian structures absent. So anybody from the audience? XY, Dr. Means Patel is mentioning XY DSD. Yes, so this looks like a XY DSD. Now the diagnosis, of course, we have to work out from there. So which test would you like to do? XY DSD, Dr. Arshad. So I think this is XYDSD. Further workup will be testosterone, and then we can go forward from there. Now carry on, Dr. Vibha.
On the follow-up, what we found that the investigation showed that LH was 1.26, FSH was 1.07, and definitely, as the sir said, testosterone should be done, and it was 146 nanogram per DL, which is
So what does it mean is
which
that
has
there is a mini puberty going on
puberty.
and testo is high. So
Right.
which form is excluded from this?
Sir, from me or the audience?
So yeah, audience. Yeah. So which forms will be excluded? So Dr. Vibha, you can now mention because people are not
So,
coming.
in mini puberty, if the testo is high, then definitely the AIS, which has no, absent mini puberty, is ruled out, and the proximal defects, like where all the metabolites are low, like SCC and STAR
Definitely, we are
are low.
not dealing with SLO, SCC, star side chain cleavage. DHT is found to be low. So now the diagnosis, I think, is very
Fiber.
evident. This is more likely to be a 5 alpha reductase. High testo, low DHT.
Low DHT.
Yes.
So another case, we have this 8-year-old boy who presented with precocious puberty, and on examination there was a hypokalemia with the high blood pressure of 120 by 74,
So I
and
think this is a diagnosis which is very evident. People can venture there. There is a boy who comes to us with precocious puberty, hypertension, and hypokalemia. Diagnosis from the audience. So in diagnosis is evident. Dr. Sandeep is mentioning 11 hydroxylase deficiency. Yes.
yes,
So further, you had metabolic alkalosis. So 11 hydroxylase is there. Now, of course, can this be a XX and XY both, Dr. Vibha?
sir. In the XY, this XSDSD doesn't present with precocious puberty. It presents with delayed puberty in 11 hydroxylase deficiency.
But if it is a XX-DSD, as we discussed, if there is a female who is completely virilized, may present to us with extreme
Yes.
cases of precocious puberty. So,
Yeah,
we look at the gonads which will give you. So, of course, this is the boy, so there will be gonads which are present. Next one.
So we have this 3-month-old child who presented with the DSD. He was diagnosed with DSD. On the examination, what we found that the Prader stage was 5, but there was no palpable gonads, and the blood pressure was normal in this child. On the USG, what we found, the Mullerian structures were present. Potassium was normal, sodium was normal, and 17 OHP was within the normal limit, and the karyotype was found to be XX.
So this is a clear-cut case. We have got somebody who has got no palpable gonad, Mullerian structure present, XXDSD, CH ruled out diagnosis. I think from the audience, it should come quickly. So what do you think is happening to this girl with XXDSD with normal 17 OHP? Most likely diagnosis, and what question you will ask from the on examination? So SRY gene, less likely, but yes, theoretically yes. Anybody else? You will not actually have an issue in terms of atypical genitalia. So Dr. Alappan is talking something. I'll wait for some other responses. If there is maternal virilization, aromatase deficiency, Dr. Divyalakshmi, absolutely. So Dr. Vibha?
Yes, sir. Definitely history of maternal virilization and like parasitism and acne during the pregnancy should be asked in this case. And this is a case of diagnosis, and so
It's aromatase.
definitely it is aromatase deficiency.
Yeah.
So we have this 2-week-old girl who was born at 34 weeks, and she was presented to us with a clitomegaly. There was no this scrotal development, like no ruggies. There was no palpable gonads. On examination, clitoris was found to be this 6 mm only. So what is the most likely diagnosis in this case?
So I think the question would be whether you would like to do a workup in this.
Workup.
Or not. Yeah. So weight, yes. So I think that is what this is a normal scenario. No need to work up. If you do work up here, you may find very high levels of LHFSH, which are normal for premature baby. So Dr. Means Patel is also saying reassurance. Yeah.
So next we have the 16-year-old girl who presented with primary amenorrhea. On the examination, she had a breast stage of 4 and a pubic hair of stage 2. There was bilateral inguinal swelling. On the investigation, we found that the LH and FSH and testo was high, but there was low DHT. ultrasound showed no Mullerian structure and the karyotype showed the XY type. So what is the most likely diagnosis?
So I think the diagnosis is already mentioned is very easy in terms of antigen insensitivity. I think the question which I like to put is when would you like to do a gonadectomy? So from the audience, would you think gonadectomy is required now or we can consider it later on? Because this is a XY individual, there is a risk of malignancy, so we need to be cautious whether you like to do a gonadectomy now or a bit later. So any response from there, from the audience? Dr. Sandeep is saying now, so already the puberty has happened. Okay. Any other options? Dr. Vibha, what will you think?
Now, sir, during after puberty, we should go for the gonadectomy
So
in this
already
case.
puberty has happened. There's no point waiting anymore. So there will be a risk of malignancy. Yeah. So you can go for fact check now. Has Dr. Nimisha being able to join with voice? Dr. Nimisha? I think there is a voice. Okay, you try to speak, maybe. So I think there is some audio issue. So anyway, so Dr. Vibha, you can start off with the fact check. Yeah.
So you have to say whether it is right or wrong. So coming to the first one, the most common enzyme deficiency in the case of CH, is it a 21 hydroxylase deficiency or not?
So we'll wait for the audience. I think people have started coming. Dr. Sandeep, Dr. Means Patel, all of them are saying yes. So I think that's clear.
Yes, sir.
Next one, please.
Coming to the second one, the presence of gonads rules out excess DSD. Is it a correct statement or not?
Yes. So again, people can answer that question. We are waiting for answers. Dr. Sandeep is saying yes. And Dr. Priska is saying no. So what do you think?
Presence of gonads definitely rules out.
Yeah, generally they will rule out, but you can have some rare scenarios. So I would say definitely I would take it that yes, it rules out. Yeah, carry on with the next one.
And so the DOC in the drug of choice in CH is prednisolone. Should we use prednisolone in CH or there is some other drug?
And I think the caveat would be whether this is a growing child. So we're talking about in an early stage.
Early CH.
So Dr. Priska, I agree, you can really have XX testicular DSD as well, which is a rare scenario. So definitely we should not use prednisolone. Dr. Ayesha is mentioning that. Dr. Irshad is talking about that. Hydrocortisone will be a better drug because it will got less growth inhibition.
Sure.
Yeah.
Coming to the next question, is every child with 21 hydroxylase deficiency present with salt wasting or not?
Yes, a very important question. So we'll wait for the answers. So Dr. Irshad is saying no, Dr. Sandeep is saying no, a lot of people are saying no. So yes, that's true. But what we need to remember is that most of them will have covert mineralocorticoid deficiency. And that's why you need to give mineralocorticoid even for the simple virilizing form. Otherwise, you will need a lot of hydrocort to manage from that. Yes, next please.
Can non-classical CH female present only with acne and hirsutism?
So let's wait for the answer. So non-classical CAH can present with acne and hirsutism. Of course, that is the classical presentation. Dr. Aisha, Dr. Sandeep, Dr. Irshad, everybody thinks this is a right answer. Yeah.
In 17 hydroxylase deficiency, does it present with XDSD or XYDSD?
Okay, so 17 hydroxylase XX or XY. So we have discussed this already. If you have 17 hydroxylase, you have a problem in androgen production. So Dr. Sandeep is talking about XY with hypertension.
Yes.
So we have got XY from Dr. Irshad, Dr. Parag, Dr. Aisha, everybody. Yeah.
The next question, is the treatment of choice for simple virilization CH is only hydrocortisone or another drug should be added in this case?
So simple virilizing form, are we going to treat it predominantly with hydrocort or do we need something else? This is something which I discussed. So probably people can just answer on that. We have to add fludrocortisone as well because they have covert mineralocorticoid deficiency. Dr. Sandeep is mentioning that. Yeah.
Um, if the patient is presenting with hypertension in the XY-DSD, is it the 11 hydroxylase deficiency or there is some other probable diagnosis in this case?
XXDSD with hypertension.
Hypertension.
Yeah, so I think this is a case which we discussed. So 11 hydroxyl is true. A lot of people are talking about that. So that's a true answer. Yeah.
Coming to the next one, newborn screening does not include CH screening. Is it a true statement or false?
So definitely we should go for a CH screening. Dr. Parag is saying false. We should include this as
Yes.
part of the test.
Coming to the last one, the virilization in newborn is assessed by Prader staging or there is some another staging for it.
Okay. So we discussed about two scores, Prader staging for XX and EMS for the XY. So if we're talking about virilization, we're talking about XX. So here Prader will be the ideal one. If you talk about under virilization, we'll think about the XY.
Yes.
So I think this was a very interesting session. We will close the session here. We'll have some question answer. So I like to go through all of you can go through our application, our publication and courses which are there available online.